Welcome to Cardio Care Live, sponsored by the Johns Hopkins University School of Medicine. My name is Dr. Michael Miller, and you are tuned in to a live session called Can We Reduce Residual Cardiovascular Risk by Optimizing the Lipid Profile? With my colleagues Dr. Henry Ginsberg and Dr. Roger Blumenthal. Today's program is the third installment of a monthly learning series on residual cardiovascular risk. If you missed our first two lunch sessions in May and June, you can still access the program in the on-demand auditorium at cardiocarelive.com. Now, before we get started, I would like to remind our audience that we will be taking real-time questions throughout the presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen. Now, my guest, Dr. Ginsberg, is the Irving Professor of Medicine at Columbia University College of Physicians and Surgeons, Associate Dean for Clinical and Translational Research, and Director of the Irving Institute for Clinical and Translational Research at Columbia University Medical Center in New York. He is Principal Investigator of one of the first 12 NIH-funded Clinical Translational Science Awards, or CTSA. Dr. Ginsberg is also Principal Investigator on 2 R01 grants from the NIH and HLBI. He is also the Co-Principal Investigator at Columbia on the ACCORD trial. His research interests have focused on the regulation of plasma cholesterol and triglyceride levels, particularly the metabolism of apolipoprotein B-containing lipoproteins in cells, mice, and humans. He has authored or co-authored more than 200 articles, reviews, and chapters related to lipids, diabetes, and heart disease. My colleague, Dr. Blumenthal, is Professor of Medicine in the Division of Cardiology at the Johns Hopkins Hospital in Baltimore. Dr. Blumenthal has co-written more than 200 publications on various aspects of cardiovascular risk assessment, as well as atherosclerotic vascular disease, detection, and management. He specializes in persons who have a family history of early heart disease, as well as those adults who developed heart disease at a young age. Good afternoon.
Good afternoon, Mike. You left out that Dr. Ginsberg is an avid Yankee fan, and I think that's probably one of his main interests, too.
Right now, the Yankees are actually killing the Orioles, and so
the Orioles
we don't like to talk
bad.
About that.
We won't mention any of that.
Well, it's great to have both of you today, and to basically advance what we've learned in the first two sessions. And the first two sessions, in effect, included my colleagues, Dr. Blumenthal and Dr. Sergio Fazio and Vera Bitton, and we honed in on residual cardiovascular risk and getting to know the elusive but real enemy. We talked about women, special populations in our previous session, and today the focus will be on ACCORD. Since we have our principal investigator here. So I'm going to start by really reviewing some of the information that was presented in our previous discussions. So perhaps if we can advance our next slide. First, I'm going to show you our disclosures. And the disclosures for myself, Dr. Blumenthal's long list, and Dr. Ginsberg's. And now our objectives today, participants who are listening in should be able to apply the results of the important studies related to CV disc reduction, especially in patients with diabetes, and to outline the conclusion of the ACCORD lipids trial, explaining the importance of these findings for the clinical management of cardiovascular risk in our patients with diabetes. And so, to recap, in our previous program back in June, the question is, why should we not ignore residual risk? I think we all know as clinicians and healthcare practitioners that residual cardiovascular disease risk is high, remains high in both patients with coronary heart disease as well as our diabetic patients, even after treatment with statins. And the likely basis for that stems from the persistence in atherogenic dyslipidemia, as defined as elevation in non-HDL cholesterol. We'll talk more about that, and elevated triglycerides being part of that in our clinical results, as well as low HDL. We know that ATP4 is due out later this year, perhaps at around the AHA timeframe. I'm going to say sometime in November or December. We also know that that will, in large part, be influenced by the evidence from studies that have come out since ATP3 was released. So we have close to about 10, 11 years worth of studies. And as well, there are a number of ongoing clinical trials that are determining now whether combination therapy may be clinically superior to statin monotherapy in our high-risk patients. So again, why should we not ignore residual cardiovascular disease risk? You may find both the June program and the May program on demand at www.cardiocarelive.com. And now, just in assessment of non-HDL, because we talked last time, both Sergio and Vera and I discussed the importance of non-HDL, and the idea came up that when we look at plaque composition of cholesterol, that while the majority of cholesterol derived in plaques originates from LDL, approximately 1/3 of cholesterol deposited in plaques probably is derived from some of the non-HDL or not other components outside of LDL, such as remnant particles. And so looking at all the atherogenic lipoproteins, we have non-HDL comprised of the ApoB-containing proteins in LDL, IDL, VLDL, and chylomicron remnants. For simplicity, traditionally, both VLDL and LDL, which encompasses the majority of non-HDL, will be used in the derivation of the formula. So non-HDL, simply total cholesterol minus HDL, or 30 milligrams per deciliter above the LDL goal would be the non-HDL goal. Now, the current treatment paradigm from both the American Diabetes Association and ACC consensus statement is outlined on this slide, with treatment goals shown here, those with very high risk based on having known cardiovascular disease or diabetes and a CVD risk factor. The LDL goal is suggested of less than 70, again non-HDL 30 points higher, and the recommendation of ApoB. And then in high-risk patients, defined as 2 or more risk factors or diabetes, an LDL goal slightly lower or slightly high to less than 100 or less than 130. So I wanted to open this up to both of you.
So Mike, I have a question for Henry and yourself. Here at Hopkins, Peter Kritovich looks at this slide and would always say, that ApoB target should be lower, and he would say that in Haynes, Henry, maybe the 10th percentile for LDL is 70, and the 10th percentile for ApoB is 60. So he always, when he's talked to our group in cardiology, he would always say, you really got to be aiming for a much lower ApoB of 60, and I was curious what your thoughts were, and do you agree with sort of having that ApoB of 80 as opposed to lower than the LDL?
But going back to the very early work that Peter did with Alan Snyderman, where they measured protein, which is almost all ApoB, as well as cholesterol in LDL, normal people with normal triglycerides, normal HDL, that the cholesterol to protein ratio is about 1.2 to 1.3. So you could argue, therefore, that for an LDL of 70 would be an ApoB of 60 or even in the 50s. So I think those numbers, though, come from some of the clinical trial data looking at risk. And we're down at the bottom. It's hard to say. It probably is, those numbers of 80 and 90 are probably, well, the 80 is a little bit out of line, I think. The 90 is at least on the right side. It's lower than the 100 for the LDL cholesterol. So you could make an argument there that there's only this 10 milligram per deciliter difference in ApoB. There's a 30 milligram per deciliter difference. But I guess the best data was for a flattening out somewhere around 80. We'll probably get more data when we get trials like Improve It, where everybody is going to be that much lower, or some of the trials coming down the road.
Right, and I agree, Roger, in as much as that ApoB is obviously a parameter that a lot of our clinicians might use. One of the issues that continues to come up is the task that the writers of the national guidelines have to come into as they frame these guidelines, and their task is in large part now evidence-based. So
right.
it comes down to a number of issues. In fact, my colleague Harlan Krumholtz over in New Haven has even suggested that we do away with levels per se, using the idea that a statin, for example, is a medication that is a cardiovascular risk reducer.
Right.
And so I just wanted to see if you might agree to some extent about using cut points when there is not clinical outcome data in all cases to support them.
So I guess I would disagree with Drs. Haywood and Krumholtz, because if you took familial hypercholesterolemia, should we just give 40 milligrams of atorvastatin, or can we show that you can get some more regression of xanthomas, maybe studies of CT angiography looking at soft plaque showing some regression? And I think the totality of the evidence that Charlie Hennekins would always like that phrase, would be that you can stabilize plaques more, you can get some modest regression with further lowering, just rather than just giving a high dose of a statin alone. But I think it's incumbent upon us to look at the clinical trial data, which Henry contributed so much to when we get to the Accord study about that particular intervention. How much more did that add on to a statin?
You know, the Canadian guidelines took an intermediary, I think, approach, and that is, they said, if someone needs statin therapy, then the goal should be a 50% reduction, which limits the dosimetry there and the choice of drugs, albeit. But what if 50% reduction leaves you with an LDL of 110 or 120? Right. So, although I must admit, and I think we'd have to all agree, that FH patients, we don't know that if they don't have hypertension, they don't smoke, et cetera, don't have diabetes, if you take them from 240 to 120, what is their risk? And I think it's probably not as high as someone who has the metabolic syndrome, insulin-resistant diabetes, who goes from an LDL of maybe 190 to 100. So, I mean, and that brings up the residual risk or other risk factors that remain. So if you take LDL down 50% and there are no other risk factors, we just don't have data on what types of rates of events people have, because we haven't studied enough FH patients.
But you do have some data from Accord that may help us
in this other group.
In this other group, but not the pure high LDL
right,
group.
That's right.
So why don't we talk about that? And since we have the honor of Dr. Ginsberg's presence here. So Henry, I'm going to let you take over.
Okay. So I think by now this paper came out 2 years ago, and I think most people are familiar with the bottom line, which I'll describe. Just to remind everyone, Accord was a very large study that the primary focus of looking at the effects of intensive versus standard glucose lowering on cardiovascular outcomes. There were 10,000 people randomized about equally to hemoglobin A1C of 7.5 or so versus a hemoglobin A1C of less than 6. Within that overall design, there were two sub-studies, a blood pressure study, which had goals of less than 140 and less than 120 systolic blood pressure, and that was in about 4,500 people, and a lipid arm, which I led, which had 5,500 people, with the idea that we were going to, as shown on the next slide, address the question of whether combination therapy with a statin plus a fibrate would reduce cardiovascular disease compared to statin monotherapy in people with type 2 diabetes who were at high risk. And this was a high-risk group. About 40% had had an event, and those who had not had an event needed to be of a certain age and have two risk factors beyond diabetes. And so a very high-risk group, we estimated that their event rates would be about 2.5% per year on a statin and on other cardiovascular risk reduction medications, and actually that's what the placebo group did. So we have everyone on a statin, The average dose was close to 30 milligrams per day. Half the people, 2,700 or so, on fibrate, fenofibrate at 145, and the others on a placebo.
But not everybody in the trial had symptomatic coronary disease.
No, as I said, 40% had had an event and, or had angiographic evidence, but certainly at high risk. The average age was about 63. It was about 35 men to women in the trial. An average duration of diabetes was 10 years. Okay. The bottom line was, as again, people I'm sure know, a disappointment. We had a hazard ratio of 0.92, or estimated difference between the groups of about 8% lower event rate in the group on pheno versus on placebo. To put this in a little perspective, the LDL levels in both groups were 80, so they were very close to or at goal for whether they were secondary or primary prevention and with diabetes. I guess the ADA now, after we designed this trial, would have said everybody should have been under 70, but we had a mean of 80, and it was equal between the two groups. Almost everyone was on aspirin or an ACE inhibitor, many on beta blockers, especially the secondary prevention group. And with that in mind, with about a 20 to 25% difference in triglyceride and about a 4% difference in HDL cholesterol, we did not show significant benefit.
Now again, just to point out, if you look at the primary outcome in the placebo group, you're having an annual event rate of about 2.4%. This, you would expect folks that have coronary disease, now again 40% have a coronary disease and diabetes, without taking statin, the natural history is about a 4% annual event rate. So again, showing that in the statin era, how well treated both with statins and aspirin, that the rate really comes down to a much lower level.
And actually, in the group who had had an event, the event rate was about a little under 3.5% per year. The group that had not had an event, the event rate was about 2% per year. Okay. So that and there were male and female differences you might expect. I think a point to take home from this is that diabetes is in women who have not had an event, women with an average age over 60, with 10 years of diabetes and with risk factors, at least on statins and on other medications, and so maybe it's a little circular here. They had event rates down around 1.5% per year. So you can really drive those event rates down. They're still higher than we'd like them to be, of course. So when you have a negative outcome in an overall trial, you tend to look for heterogeneity amongst the participants to give you some insights. And this is a sort of a typical forest plot of subgroups, and I've put the red lines around males and females, because this was actually the most striking interaction that we saw. That is, if you looked at the men and the women separately, they clearly had different outcomes, fenofibrate versus placebo. The men had about, as you can see here, the men had about a 30% benefit. They had much higher event rates than the women, double the event rates in the placebo group. And then the women had a tendency toward harm, actually, to be blunt about it. Some people don't like to hear me say that because the confidence limits are wide, and so there's nothing statistically significant here, but you can see the hazard ratio is about 1.4 for women in this trial. They had very low event rates, about 6% over 5 years, so a little over 1% a year, but it went up to 9% on fenofibrate.
Are you able to tease out anything between why the women behave differently than the men?
So we've looked at that, and we have a paper that's being, a manuscript that's being developed. But I can tell you that men and women, by their baseline characteristics, really didn't look different. Their fasting lipids, the women actually had the same triglyceride as the men. We often talk, we know that women have lower triglycerides. than men in general, but not when they have diabetes. The HDLs were about 4 points higher in the women than the men. It was 41 in the women versus 36 in the men. Maybe that's a larger drop from the 50th percentile for the women than the men. And we know that happens as well with diabetes. Their response to therapy, the women had the same response on triglyceride, not as good a response on HDL, but both groups, it was a modest response on HDL.
Any difference in other demographics like smoking or some other confounders?
Smoking, no. Again, women had less secondary prevention than men, demonstrated by their overall event rates as well. So we don't have evidence at the first level. We did find, though, that the difference in events, which was there were about 16 more events on pheno than on placebo in the women, versus 30 less events in the men, that the women had, the increase in events was all in non-fatal MIs, not in mortality, not in stroke, but non-fatal MIs. And so then we looked a little further, and we looked at the men and the women in terms of primary and secondary prevention. And in the men, and again, you're starting to now cut up borderline numbers overall, and so we're down in a level where there's not much in the way of statistics to do. But primary prevention in the men didn't do much. Secondary prevention in the men, there was a very nice benefit of about 30%. In the women, interestingly, nothing much happening on the primary prevention side, but the women who had had a prior event actually had a 70% increase in events on phenofibrate. They made up that hazard ratio of 1.4. And so looking at, and there's only, now we're talking about a group of 200 women on pheno and 200 women on placebo. If I look at the entire secondary prevention cohort of women versus the primary prevention women, much more in the way of proteinuria, higher rates of heart failure, higher rates of amputation, higher rates of laser treatment for retinopathy, and much more beta blocker, much more ACE inhibitor, a very sick group. What I haven't obtained yet, I need to go back and look to see how they randomized out. You'd expect they would have randomized equally to placebo and pheno, but with 200 people in the group, maybe there was some loss there of randomization that could explain the increase.
Sure, and you think the duration of diabetes in this group was not different? You said about 10 years.
That wasn't different, but they were a very sick group of women. It was just sort of a referral bias maybe to get into the trial. So we're left with this enigma, and I'll get back to what my conclusion is and what this leads me to believe. So the second group we looked at was the dyslipidemic group. And just to make it clear, all of these subgroups were pre-specified. And in the original protocol design, we said that we would look at the effects of lipid subgroups across the range of lipids. So we didn't pre-specify it to the 10th degree, but we knew we would do quartiles or tertiles of various lipids, and so we decided for tertiles, and we did LDL and HDL and triglycerides separately, and didn't really see much. And then we decided to do a combination of the upper tertile of triglyceride and the lower tertile of HDL. Didn't want to take any arbitrary cuts. So we ended up with the upper tertile starts at a 204 milligram per deciliter. So pretty close to, to what people would take as a cut point. And the lower tertile for HDL was 35 or 34.
And was that for both the men and women combined?
Yes, that was combined. And I should have said earlier that one of the shortfalls, the shortcomings of this trial is that we did not have strict lipid inclusion criteria. And I'll get back to that at the end of my presentation, but this was a very, very heated topic, a lengthy discussion when we designed the trial. And I clearly wanted people with higher triglycerides and lower HDL. But this was a glucose trial. And to have a narrowing of patient characteristics to fit a lipid sub-study would have skewed the overall trial result and would have made recruitment more difficult. And so we had no triglyceride inclusions. And that's why we ended up with a median baseline triglyceride of 163.
Right, and I think that's an extremely important point.
Right.
If you're just joining us, welcome. This is Cardio Care Live, and we're talking about non-HDL, the elusive enemy. How could we reduce residual risk with my guest, Doctors Roger Blumenthal and Doctors Henry Ginsberg. And Henry's just telling us about the intricacies of the Accord trial, which he was fundamentally involved with. So I think this is really pivotal, because you were armed with all this great data showing in previous trials, especially some of the fibrate trials that had predated Accord, that we know that the low HDL or high triglyceride group tends to do better, whether
Right.
it was BIP or whether it was some of the preceding studies. But you couldn't, that was
We
not
were
sufficient.
able to convince our colleagues that we needed a truncation of HDL. And so for the lipid arm, we had an HDL of 50, except in African Americans and women, we made it 55. And so that probably gave us, in the tertile picture here, that's why the upper tertile for HDL was 35. It might have been a little higher if we had no truncation there. And it probably drove the triglyceride a little higher, since they, and finally, if you just do the arithmetic, if you have an upper and a lower tertile, you'd expect 9% of people, approximately 10% of people, to be in that. We had 17%, probably because of both the truncation of HDL and because of the fact that triglyceride and HDL are inversely related, and they come as a package. So you can see on the slide that we just missed significance for the p-value for the interaction of dyslipidemia or not with the outcome, but it was very close. And you can clearly see some striking points to make. First of all, without dyslipidemia, all others, 83% of people in this trial had an event rate over 5 years, or a little less than 5 years, of 10%. And nothing, zero, that's a hazard ratio of 1.00, happened on fenofibrate. On the other hand, the event rates in the triglyceride group, in the placebo, was about 18%, and it dropped 27% overall with the men and women combined. And so that by itself had a nominal p-value of 0.03. I always say, if I was truly prescient, when I was handed the protocol and saying that we didn't have any exclusions for triglyceride, I should have said fine, but I want my primary endpoint to be the top third of everybody. And I might have come home with a winner.
So along these lines, if you were to design a trial in the future, to address some of these issues, you would really focus in on perhaps a hypertriglyceridemic low HDL group.
Absolutely. And I think that's reasonable. I mean, those are the people we treated with fibrates. I mean, I think a take-home message, before I get on to a little bit of the more details here, is that in my own practice, I would have used fibrates for people with TG certainly over 200. I might have dropped that a little bit if they had a very low HDL, but I think you may have had the same experience. If you put someone on with isolated low HDL, meaning a triglyceride certainly under 150, but an HDL in the low 30s on a fibrate, the results were pretty bad. I mean, I've never been impressed by seeing anything happen there. It was you always needed a significant drop from a high TG downward to get a good HDL result. So we looked a little more carefully at this group, certainly, and first of all, by definition, comparing the 17% with dyslipidemia, they had a much higher triglyceride. Those are medians. They had LDLs that were extremely low. This is men and women, the bottom two lines. So, but the average is about 30 for HDL compared to about 40 in everyone else. When we looked at response to treatment, on a percentage basis, the response for the dyslipidemics was close to 25%. It was between 20 and 25% lowering when you do a placebo correction. For the non-dyslipidemics, it was about 15%. So very little benefit from fenofibrate in 83% of the people in the trial. On an absolute basis, we're taking people with a median of 285, and we're taking them down to 160. Right. Whereas in the other group, we're going from 144 to 120. So there's a big difference in absolute TG, and I don't have. We will get ApoB in VLDL as part of an ancillary study we're doing now. We don't have that at the moment. For HDL, again, even in the dyslipidemia group, placebo-corrected was modest, but it actually comes out to about 7% increase because the denominator is so low. But if you look at 83% of the people in this trial had nothing happen to their HDL at all.
Interesting.
And so we gave a drug to 83% of the people and it didn't have any lipid effects.
Now, one of the questions that's come up is whether or not there were differences in prior HRT use for women who were assigned to either placebo or fenofibrate.
So despite the age group, we had, I think there were 3% of women were on HRT during the trial.
Not a whole lot.
No. Probably related to those studies that have come out
during the time
period. Okay. So then we looked at the gender difference again in this dyslipidemia group, and this certainly I need to go further and do a little more data mining. But what we see here is the men having a 31% reduction in events, the women having about a 12% reduction. So despite the fact that women as a whole, particularly the secondary prevention group, seem to do worse, the women with dyslipidemia, with very wide confidence limits, obviously, seem to be on the right side. They may have had some benefit. And that's a very interesting finding. And I think, again, the take-home message from these subgroup analysis to date, my own take-home for myself is, if I'm going to use a fibrate, it's going to be in someone whose TG is above 200 and they have a low HDL. If I'm going to push that TG down at all, it won't be in a woman. It might be in a man. But we need to get to the bottom of that secondary prevention, primary prevention difference in the women. The next slide is, we had this in the supplement to the New England Journal article. They wouldn't let us put it into the main paper. We already had our limit for figures and tables. But I think it's really, it goes back to what you said, Mike. We looked at the previous studies, so HHS, Helsinki Heart Study, positive study overall, but a later paper, a post hoc analysis looking at people with high TG and a high LDL HDL, which in part would be low HDL, and they double the benefit they get from 35% to 70%. BIP, a trial that's negative overall, but when they look at TG over 200 subgroup with or without a low HDL, in fact, in their studies, they get a 40% benefit. The field trial, negative overall, using arbitrary criteria, and all of these previous trials were post hoc analyses, using the 204 and an HDL of 42, I guess it is, they get a positive outcome. And the numbers are very close to ours on the last line. Negative overall and this 31% benefit for the pre-specified subgroup of upper tertile, lower tertile.
And this goes beyond fibrates, because this is also seen in the omega-3 jealous study as well. The hypertriglyceridemic low HDL group tends to do better, even though that was not, again, specifically a primary hypertriglyceridemia population.
Right. Just want to finish up with covering one other area that was that's important for physicians to know about. And there are two papers. One's in Diabetologia and one is in Diabetes Care. The second one is the point I'll make here. But we did find out, and to my dismay, and I just missed this in the design of the trial because the literature just was very, very scattered and limited, that PPAR alpha drugs in general raise creatinine levels. And fenofibrate is almost the champion for that. And you can see here, our first blood sample was at 4 months, and creatinine, the red line in the pheno group, had gone up almost about 15–16%, and compared to the placebo. And over the course of the rest of the trial, those numbers stayed parallel. Everybody crept up. These are older diabetics with a lot of vascular disease.
Didn't matter what their baseline creatinine was. Did that influence?
Well, baseline creatinine is a predictor. The Diabetologia paper is all about predictors, and a higher TG was a predictor, actually, and also the change in TG was a predictor. Maybe it has, if you got a better response to a PPAR alpha agonist, this happened. So, of course, the question is, what does this mean? And in the New England Journal paper, we show that despite this difference, no one went on to end-stage renal disease or dialysis in the trial. But more importantly, there was a reduction in micro and macroalbuminuria in the group taking pheno over the course of the trial compared to the placebo group, despite a rise in creatinine.
So despite the increase in creatinine, there was some benefit in some of the microvascular.
So Henry, do you advocate that if someone has, say, a baseline creatinine of 1.4 or 1.5, that you not use the, say, 145 milligram dose, but a lower dose? Or?
So let me show you the next slide, and I'll get back to that.
Sure.
So this is from the Diabetes Care article. What we did is, we just took sort of people that met criteria of, we had a placebo group, we had a group on pheno, and we had people whose creatinines did not go up more than 2%, and we had people whose creatinines went up over 20%. So it's arbitrary cuts, and then it was sort of who we could convince to do this extra study. And what the extra study was they came back 6 to 8 weeks later, and we drew some blood and got some urines. And what you can see here is the top lines look at the estimated GFR at baseline. And they were all in the around 90 to 95. Okay. Then the group at the end of the study, close to 5 years, that last visit, you can see that if we start on the right and look at the placebo group, they dropped to 80, or about 80 mils per minute, per meter squared. And so they dropped from 90 to 80. If we go to the middle group that didn't have a rise in creatinine, they dropped about the same way, to about the low 80s. And then, of course, the group that had a rise in creatinine, they dropped to the high 60s because they had a rise in creatinine, and that's how you get the estimated GFR. 6 to 8 weeks later, that bottom line, the group on pheno had that big drop in GFR, goes all the way back up to the low 80s, and now equals the placebo, people that were on placebo all those years. So this is a completely reversible phenomenon. And the group in the middle actually ends up at 90. Now, I don't know, I don't want to say that means that if you're on pheno and you don't have an increase in creatinine, it's actually protecting you from the expected. These people probably just had better renal function, or they didn't, I don't know. But let's just take the ones on the margins there. It's a completely reversible phenomena after 5 years, and I think people should take this into consideration when the creatinine goes up, if it does in someone on pheno. I personally, the mechanisms that have been discussed include increased protein synthesis in muscle with more creatine being made. There's some animal work to support that, and there's some soft evidence that CK levels parallel creatinine rise, but that could be confounded. There's a hypothesis that we all secrete some creatinine. About 5 to 10% of what we put out in our urine comes from the tubules rather than glomerular filtration. And there's a little bit of evidence from some animal model that maybe that's blocked by PPAR alpha. And then there was some data suggesting that PPAR alpha cause vasodilation of blood vessels everywhere, but maybe also in the afferent arteriole. And that would be an ACE inhibitor like effect,
Right.
which would be reversible and might be associated with less proteinuria because of a drop in glomerular pressure. That's my favorite hypothesis, but we don't have evidence for any of those. All I can say is that if the creatinine goes up somewhat, I think it's safe to say, as long as proteinuria is not going up at the same time, and it should be going down, that this is a reversible phenomena. We also, in the Diabetologia paper, looked at cardiovascular events, because you could say, all right, it's reversible, but maybe it's not good to have a high creatinine for 5 years. There was no difference in cardiovascular events among these groups of individuals.
Again, provide reassurance. What about those that were also, because a lot of the patients were taking ACE inhibitors, were there any differences in overall renal function or progression of
I don't think,
creatinine?
we just don't have enough numbers to look at that in this. Although it might be in that regression model. I'm sorry, I don't remember offhand. So I think that brings us to the cases. But again, my take-home message, obviously, a big disappointment, as were the other arms in the court overall. But I think it might have been, it was predestined in a way to be a negative trial, because we were treating 80% of people who wouldn't have been treated with a fibrate in clinical practice with that drug.
So just one thing to add, I guess, Henry, you've seen this a lot too, that many of our referring physicians seem to place a lot of emphasis on particle size. And we've had patients come to us where the doctors say, you know, your LDL may be a little high, but you have pattern A, and you really don't need to be treated aggressively. And conversely, many times with sort of the advanced or accessory lipoprotein tests, they come up with you have pattern B, and you have to be on a second agent. I think one of the lessons of ACCORD is that, you know, at least at 5 years, adding that second agent in these people who undoubtedly would have had pattern B because their mean triglycerides were somewhere in that 165 range, you know, didn't help. So I think, you know, the people who said you're not doing your job unless you got a VAP test or if you got a liposcience test, you know, at least this shows you that that information you get from that test therapeutically really didn't lead to a change over the next 5 years. Mike, I don't know.
Well, you know, it's both a compositional change as well as particle number, which some studies suggest might be important. I don't know if you're looking at particle number, is that right?
We were funded by the NIH to do some additional. You know, it's amazing, sort of sad in a way that a study that cost hundreds of millions of dollars, the whole overall trial, ends up with simply having lipid levels and nothing else. But we were funded, so we're measuring ApoB, ApoA1, ApoC3. We've a case cohort designed with 1,800 people. So we're measuring those 3 apolipoproteins, we're measuring CRP, we're measuring homocysteine, which we know goes up on fibrates. And then we're getting particle size and number, Ron Krause's laser diffraction densitometry method. I think we're getting, it's a new method that's out there, and it gives a direct measure of particle number as well as particle size, but we're also going to give samples to liposcience, so we'll see. I mean, one could argue, though, Roger, that the dyslipidemic group probably had the smallest LDL, and it was probably the only group where the LDL significantly changed in size. I certainly don't base my approach on LDL size because they're the people who have high TG and low HDL,
right.
And so I'm already, I always tell physicians that I talk to at lectures that the one reason I think they should think about the size of the particle, it's the obvious one, that if 2 people have an LDL cholesterol of 100 and one has small particles and one has big particles, the person with big particles has fewer particles. Right. And so if you just lower their LDL cholesterol equally, you'll still have more particles in that person with small particles. But I don't think you have to, personally, I don't measure it. Maybe it is helpful to someone who's, you know, does more medicine than I do, and not just a specialist. But it'll be interesting to see how what that looks like in this particular sub-study.
Right, and the only other question that, before we move on to the case, the only other question that has come up with regard to fibrates, is benefits with regard to the microvasculature. So I wonder, do you have any information in regard to ACCORD? So,
you know, I think if people are interested in this, they can certainly read the many papers that Anthony Keach has put out from the field trial. We have, I think, the strongest data we have, and it's the only specific data that I can talk to, is the retinopathy data. And that was a New England Journal paper, and it looked at, in about 3,000 patients out of the 10,000, and divided them by glycemic arms, and then the blood pressure arms, and the fibrate versus placebo arm. Both the intensive glucose arm, which had a 40% reduction in 3-step progression by photography of retinopathy, and the fibrate arm, which had the same results, those were positive outcomes. The blood pressure reduction did not have a positive outcome. So it looked, and the fibrate effect was independent of the glucose effect. But it was also interesting and puzzling that the fibrate effect on retinopathy was not in the dyslipidemic group. It was actually in, now maybe it's a bit of a numbers game, but the point estimates were obviously different. So in any event, I think that as a first level study, and it's not need for laser, it's not visual acuity. The study was too small to get those endpoints. But simply looking at progression by fundal photography, that phenofibrate protects people from progressing. And Tony Keach has those same data, plus he has some need for laser treatment data as well with fibrate in the field trial. Should phenofibrate be used then in someone with retinopathy? There's no indication for it. No one is going for an indication for it, so it's not ever going to be something that physicians can say there's a package insert indication. Ophthalmologists have little, if any, interest in this because they don't like to give out pills to people, and they have VEGF injections and they have laser light. And I was at a meeting where that was made clear, but they'd be happy to support the idea that maybe the diabetologist ought to think about that.
And so there'll be more to come in this regard.
In terms on the renal side, overall, looking at the 10,000 people, renal endpoints were minimally affected. Other than albuminuria, there wasn't much in the way of the glycemic effect. We haven't looked at the fibrate effect.
We have a question from Paul Rosenblatt, and he wants to know whether or not you are comfortable with maintaining phenofibrate use in practice if the GFR drops from greater than 60 to less than 60. We'll ask you, and then I'll ask Roger as well.
I think everything we do, we balance benefit and risk. I think the risk of a rise in creatinine is minimal to nil. And I could ask Dr. Rosenblatt,
yeah,
whether or not what he does when he puts somebody on an ACE inhibitor and they go from over 60 to less than 60.
Right.
So I think if I'm treating someone who's got a high TG and a low HDL and I'm getting a good response, then I would think I would continue.
Roger?
No, I agree with Henry. I guess a lot might depend on how much of a rise in creatinine, how much of a fall in the creatinine clearance, and perhaps might scale back on the dose if there was a bigger impairment than we would like.
Yes, I agree. I think cutting the dose back is a reasonable approach. You don't lose that much on the lipid side, actually.
Right, and it's reassuring, though, at least in the course of the study, that there were no major adverse events as a result of the elevation.
One of the sort of problems that arose, though, was we had in the protocol in Accord, and it's on guidelines and package inserts, metformin use is contraindicated if the creatinine goes above 1.5. And so we had people going from 1.3. We had some inclusion criteria or exclusions on creatinine baseline because we would put everyone on metformin. Now we had people going over that limit, and the decision was that it was left to the investigator. And almost everybody stayed on metformin because the issue of lactic acidosis is one that we all know we should take with a grain of salt.
Well, welcome to Cardio Care Live. If you're just joining us now, and we're in the middle of a great conversation with Dr. Henry Ginsberg and Dr. Roger Blumenthal and talking about residual risk. I want to go into the cases. So let's talk about case number one. This is submitted from one of our physicians who listened in on a previous Cardio Care Live conference. And so this is a 33-year-old firefighter with unremarkable medical history. He's asymptomatic, but father died in his 30s. Patient is taking simvastatin. LDL is less than 100. Non-HDL triglycerides within normal limits. Blood pressure and A1C are within normal limits. Non-smoker. BMI is probably somewhere in that borderline range. Physically active, eats a low-fat, low-cholesterol diet. So the question is, what else can or should we do for him in terms of risk factor monitoring and control? I think I'll let Roger take a stab at this.
So since the non-HDL is normal, the triglycerides are normal, it's a pretty young individual, even though the father had the early heart disease. I think just looking at the BMI of 26, I would say I wouldn't add a second medicine now. I would just keep working on lifestyle. One could say, well, maybe the ApoB is still higher than you'd like, even if the non-HDL is a target, and some people might order an ApoB, but at this stage, my personal feeling would be that the intervention would be, try to motivate him more in terms of lifestyle.
Okay. Would you do any additional testing?
You know, the only one that I could think of was in ApoB, but I would say no. But there are some people, I'm sure, who would do it just because of the severity of the family history.
So should he be on a statin?
So
Henry, it did.
And it did say, I guess he's on Henry.
Well, he's on simvastatin. Should he remain on simvastatin?
Well, first, I would just, I would get a lipoprotein A. I've become very interested, and there are new drugs that are coming down the pike, hopefully if they make it all the way to the end of their clinical trials, that lower LPA by 40%. Both the PCSK9 drugs do this, and so do
CETP inhibitors.
The CETP and evacetrapib do this. And so we're going to have powerful ways to reduce LPA. We're not sure if that will reduce, but when I get patients like this, I find that 2/3 or 3/4 of the time with a family history like that, that LPA is high. Right. And especially if there are additional relatives like uncles, fathers. I mean, clearly the father might have smoked, he might have eaten pastrami every day, and the son's a vegetarian. So we have to make that clear to the patient that they're not necessarily their father. And I was wondering if Roger was going to say he'd get a calcium score.
I think because the age, no. If this person was 43, then I think that would be different. But the times that we miss a higher risk individual are the ones when they're young enough that they may not have time to calcify their existing plaque.
Yeah. Well, so I agree with both of you. I think I would be a little uncomfortable not treating him, even though his relative risk over the course of the next 10 years is going to be low, and even though his father may have consumed too many Nathan hot dogs, well, he doesn't. So I think I would still be uncomfortable not treating him, given that strong family history, especially because unless he obviously has problems with taking a statin. So I would treat him, and again, a young age as he is, really, I don't think would warrant a coronary calcium.
Maybe we could discuss, maybe that's why it was put in that he's a male firefighter. I mean, this young man might have to run up, depending where he lives, he might have to run up 10 flights of stairs. And so the question is, with that family history, should he have a stress test? I mean, firefighters, unfortunately, die during fires, not of maybe as often as heart attacks as smoke or fire. And
well, he's probably passed his stress test many times.
He probably has to this point.
But the other thing too, I think, right? The other thing too, and Sid Gottlieb many years ago, had shown that mechanics, exposure to carbon monoxide, which firefighters get, probably may in some way increase cardiovascular risk as well. Correct. So I think he's probably, just based on his environment, at increased risk. And I agree. I think if he was being tested, if he was inactive and he was going to become a firefighter,
right, absolutely,
I think it would be a very reasonable thing to do.
The one other point I guess we could make is that in terms of atherosclerosis imaging, while he may be too young for a coronary calcium scan, if you had access to a good lab that did carotid ultrasound, carotid IMT, that you might be able to see if this person has a high carotid IMT, and if so, potentially might go to more secondary prevention targets rather than primary prevention targets.
There was a question that had come up, I believe it was from Louise Andrew from a prior cardio care, and this I think blends in well with this discussion of Lp(a), and she asked, is there cause for concern with elevated Lp(a) in otherwise low-risk individuals?
So we only have, well, I think most of us have our own anecdotal data, and it's a referral bias, and it's often because of a big family history that of early CAD, that it appears that even with a normal lipid profile and a risk profile, that a high LPA can be detrimental. We have, from epidemiologic studies, that it is an independent predictor. I think there's some controversy as to whether the risk is very low until you get to that top 20 or 30%, or whether it's truly linear. I must admit, when I look at the data from the Dinesh paper, where they said they fit it with a straight line, it clearly didn't look like a straight line. But so I do think if someone has an LPA, if the assay is the one where it's in milligram per deciliter and it's above 30 is abnormal, is a 40, how detrimental is a 40? I think if you're 100, then I think all bets are off as to how much risk you have. We just don't know, but I think you are at high risk, and if there's a family history. Clearly, though, people, even on a referral bias basis, we usually have either we know that familial hypercholesterolemic families who have high LPA are the ones that in years gone by before they were early discovery, they had the disease, they had their CAD in the 20s and 30s. I've certainly had patients with isolated low HDL, young men who've had events in their 30s, and it was a high LPA.
Right. Mary Sita had a paper in the New England Journal many years ago showing that that combination is particularly detrimental.
And before the drug-eluting stents, certainly the bare metal stents, the restenosis rate was so high in people with high LPA. So I think it is a risk. And what do you do about it? Again, some data from the familial hypercholesterolemic patients and maybe some data from some of the clinical trials suggest that if you lower the LDL, LPA becomes less important. But I don't think we're sort of in a very gray zone.
Right. So just to make sure we all understand that your opinion on Lp(a) is that it does certainly raise risk, but in terms of screening for high Lp(a), you would reserve that for patients that are coming in with who you suspect are at increased risk.
Yeah, typically I think it's...
You're not going to do it on one of those mobiles that comes in for screening. No,
I must admit, again, I see the worst patients,
right.
But so I do it more and more. But clearly, when there's a family history of premature coronary events, in people in their 40s or below, early 50s even, I will add it on. And you only need to get it once. It doesn't change. And so I think we'll change our practice if these drugs make it to the doctor's office, the PCSK9, the anacetrapib, evacetrapib, class the CTP inhibitors, because then you'll have a way to lower LPA. It may change the way we look at the drug.
Another question that's come up relates to, and this is from Giovanni Massa Jaramilio. Hopefully I didn't destroy that name too much.
Very nice, Mike. That was very good.
It's my several years of Italian in college. Non-HDL cholesterol can be managed with exercise alone, or when do you use drug therapy?
Well, a lot depends if we're talking about secondary prevention, individual, high risk, or in primary prevention, we're going to have a little more luxury of time to see how much benefit we can get from lifestyle modification. But if someone's had bypass surgery, had a stroke, had a stent, a heart attack, etc., I think we're going to want to be much more aggressive up front and not wait as long to try to intensify therapy.
Yeah, so here's the question, and this is a common scenario. You have a patient not with known vascular disease, but who has a family history, comes in and is, let's say, mid-40s. What's your timeline? Let's say has an elevated non-HDL, has a mildly elevated LDL, let's say it's 140, should be less than 130. Doesn't really have other risk factors, family history, has a non-HDL that may be, 160, 170. Do you have a timeline by which you exert lifestyle therapy versus going into medication?
Based on the collective experience, I think, it definitely helps to set some sort of timeline. So for us, it may be 6 months. It sort of depends. We want to try to help people figure out ways they can improve their exercise habits, maybe give them a pedometer, tell them where to get one, really encourage them about ways to change their lifestyle habits, to give them as many tools as they can. Some websites, myfitnesspal.com is one we use a lot. So if you can empower people to get an idea how many calories they're taking in, how much walking and exercise that they're really doing to burn up the calories, I think you have a good chance. And whether it's 4 months, 6 months, seeing them back to see what sort of progress has been made. If you're making significant progress, you would probably go longer with lifestyle changes. So a lot also depends on what their Framingham score is.
Sure. Henry, do you?
Yeah, I would just add that we always use the term non-HDL, and we look at it in the patients who have a high triglyceride and a low HDL. But non-HDL is also high if your LDL is still high.
Good point.
So we should make it clear that if the LDL is at goal and the non-HDL is high, then we're almost always talking about high TG, low HDL. But and then we're still left, though, and I think this is a very important and unanswered question. is if your non-HDL is high, your LDL is at goal, you can lower the non-HDL by lowering the LDL further,
Right.
or by lowering the triglyceride and raising the HDL. And I have to admit, after AIM high and ACCORD, despite the subgroup that I love to talk about, I think the data support lowering LDL more.
Sure.
If you really, that's what the evidence is.
And we'll have to wait till HPS 2 Thrive comes out next
Right,
year.
and then we'll have
to get a
Improve
better
It if
idea.
it's ever finished. And
Improve It, and then a whole host of other studies.
Right.
So let's go to the poll and let's ask our participants several questions. Here's the first. Which of the following advanced lipid tests would you order for JP at this time? Would it be LPA, ApoB, LDL particle number, or all of these? Or none of these? All right, it looks like LP(a). Henry, you convinced them.
I think, again, the lesson would be a high LPLA. You want to take in, that makes you worry more about that family history, and another reason to try to be more aggressive, pushing that LDL and non-HDL down lower.
I have to admit that I've seen several patients with really high LP(a) levels, family history. One that really came home was an individual who was an athlete at the University of Minnesota. He died suddenly. He was a track athlete. So his sister came in to see me. She had high LDL and as well as high LPA. Her LPA was about 150. So
Wow.
we've seen some of them, and it's really
Yeah.
of great concern. So it looks like LPA here was the one that came in. Let's see, do we have another audience polling question? Which additional cardiac test would you consider for JP at this time? Would you do an exercise test, coronary calcium, both, or neither?
So we'll see what the audience says, then we can briefly comment before we wind up.
And it looks like exercise tests, they listen to Roger, he's too young for coronary calcium, but they also listen to Henry being a firefighter, that they would do an exercise test. Again, I probably would not do either since he's completely asymptomatic.
Yeah, right.
But what would you guys do?
So sometimes people who are firefighters, mandated at a certain age. I don't think it's less than 40, but perhaps with a family history of early heart disease, since it was at such a young age, the physician, certainly has that as an option.
yeah,
Okay.
nothing to add.
So I think with that, we are just about out of time. I'd like to thank everybody for your time and informative presentation and discussion. I'd like to thank Lupin Pharmaceuticals for their support of this important educational series. Remember, this is the third of 4 Cardio Care conferences. Please remember to complete the quiz and survey at the end of the session to secure your CME credits. And please mark your calendars for the final installment, which will be on September the 13th. I will have the pleasure of working with Dr. Peter Jones and Ernie Schaefer, who will discuss residual risk. Where have we been going? Where have we been, and where are we going? This 1-hour session will again be conducted at 12 p.m. live. This is Dr. Michael Miller. Thank you for joining us today.